All right, good evening, everyone, and welcome to tonight's webinar. My name is Adam, and I'll be your moderator. Our speaker today is Dr. Lou Graham, and he'll discuss Class 2 restorations, including some of his most challenging cases and how he overcame them. If there are any questions, please add them into the Q&A section, and we'll answer them at the end. Henry Schein is not offering CE credit for viewing or attending tonight's presentation, live or on demand, and this webinar is sponsored by GC America. Dr. Graham, take it away.
Thank you, Adam, and thanks for all your hard work putting this together. Thank you, Henry Schein, for inviting me to present tonight. So, challenging Class 2s. Okay, I'm a general dentist for 30 plus years, and I'll tell you very often I'd rather do a crown and onlay than a challenging Class 2. If you don't agree, then you haven't been challenged, and I bet you've been challenged. So, with that, what do I want to do tonight? Tonight, I really want to tackle 3 cases. I'm going to challenge the norm. I'm going to challenge the way you think. And I will definitely be open for Q&A afterwards. I'm going to show research to support my opinions. You can agree, and in this country, you can disagree. I have no problem with that. But when I teach my seminars, it's always about thinking and thought-provoking stories, and tonight there'll be 3 of them, just 3. And I want to say thanks to GC America. They have been a sponsor of mine for years and years in Catapult, and as the founder of Catapult Education, GC America is one of our most valuable partners. Thank you, GC and Michelle. So why are we seeing more challenging Class 2s? Okay, so to begin with, composites are far more challenging than amalgams. Again, I don't care what anybody has to say. Back in the day, and I haven't done an amalgam in almost 25 years, amalgams were pretty darn easy. Geriatrics. People are just aging and aging. They're living longer and longer. And given the fact that Class 2s and geriatric patients are around the cervical proximal necks of teeth, these are challenging areas, and you've all seen these. And this is driven by poor diets, lots of sugar consumption, large embrasures based on bone loss leading to tissue loss, and openly poor dexterity. Geriatric patients, they just don't have the ability to brush their teeth as well as someone with good dexterity. Power brushes, water picks, the whole business. My practice is now a geriatric practice because all my patients just got older. Implants. I'm going to touch on this tonight. There are problems with implants, and anybody who thinks, oh, an implant is the panacea of restorations, get a life. It's just not true. They're wonderful. I strongly believe in them. I restore a couple hundred a year. But when you put implants next to adjacent natural teeth, especially in the posterior, you have issues, large embrasures, and then you have long-term contact issues. Then you have access to care. You know, roughly half the population doesn't come in for routine preventative care. And then small issues become larger issues, and that'll be my first case. And I think also leading to my first case, patients really all too often wait until it just hurts. And that'll be where we'll start off. So I was the 3rd opinion for this patient, and this is case 1. She's 35 years old. Now, what's interesting is she had veneers done, and they were not good veneers. But that's another story. Some years earlier, just hadn't gone to a dentist for routine preventative care, and then was referred to me for a 3rd opinion. So she comes in with spontaneous pain, no mobility, and periodontally stable. Okay. The CBCT showed a bifurcated canal, which I will show you. No periapical pathology, which is what I expected. She's got spontaneous, irreversible pulpitis leading to spontaneous pain. Her bone levels were great. Periodontal probing's great. So what would you do in your mouth if you were 35? What would you do? This turns into like classic questions in dentistry. I look on Facebook, I look on online, community chats. Everybody's got an opinion, and I'll give you my opinion. So it was my recommendation to save the tooth. And all too often, people are just taking out teeth. Look at that great bone. They're just taking out teeth and putting an implant in at 35. And my feeling is, for as long as I can preserve this tooth, I'd want to save this tooth in my mouth. Period. End of story. So now, what are your restorative options for taking care of this patient? Oh, yes, there's the obvious, a post and core or a crown buildup leading to a crown. That's absolutely what the majority of dentists would do. And I understand that. Or you could do a crown buildup and a conservative onlay because you have a good amount of tooth structure left. Or you could do a DLFL composite with a core buildup. So you got 4 options as I see it. And maybe you're out there and you've got a 5th, 6th, or 7th, and that's fine. I'm okay with that. But these are pretty much the 4. So what would you do? So I want to, with this particular case, I want to combine the latest materials with years of research. And we're going to start off with single crowns versus conventional fillings for root canal fill teeth. And, it's amazing how many second and third opinions I get. I've got an anterior tooth coming in. They've had a root canal. They're told to get a crown for an anterior tooth with a mesial composite, or it was trauma and the tooth just died. Or a posterior tooth with the majority of tooth structure left. I mean, these are the questions. And I'm not saying not to do a crown over a root canal filled tooth. But when they did this study, and this is 7 years ago, there is insufficient evidence to support or refute the effectiveness of conventional fillings over crowns for the restoration of root canal filled teeth. Until more evidence becomes available, clinicians should continue to base decisions how to restore root canal filled teeth on their own clinical experience, while taking into consideration the individual circumstances and preferences of their patients. So this is critical, the last sentence. What are the circumstances? What's the occlusion? What's the preference of the patient? And what's your preference? Like I started off, the easiest thing to do is a crown buildup and a crown. That is the easiest thing to do. But is it the best thing to do? So then we take a look on my decision-making in this case. How much remaining tooth structure do I have? What's the occlusion? How many, like, is she missing teeth? If it is a patient missing teeth, and this is the only posterior tooth left in occlusion, that's a whole different story. What about parafunctional habits? Do your patients have parafunctional? How does that mitigate your decision-making? Of course it does. All 3 things do. So I can't say there's a perfect cookbook, never to crown or never not to do a crown. I'm just saying it's individual circumstances as based on the literature, what's best for the patient. So then you go, is this tooth half full or half empty? You can see the entire mesial half of the tooth is in place. Well, which restoration will last longer? A direct restoration or a crown? Now, think about that. Which restoration will last longer? But is there a better question? And is the better question, which restoration will allow the tooth to last longer instead of which restoration will last longer? So let's say a composite didn't last as long as a crown. But what are routinely the catastrophic effects of a failed filling here versus a failed crown? How many of you have held a tooth, a crown in your hands, you look inside and you see the entire crown build up in, and there's nothing left of the anatomical tooth. Then what? Well, in this case, again, composite versus crown. And then I ask myself, by taking away the additional mesial half of this tooth, the occlusal, the buccal, and the lingual, will that jeopardize the long-term survival of the tooth itself? Now, I know many of you won't agree with this, and it's okay. But after doing my dentistry, my style, conservative dentistry, it's independent ways of thinking, not always thinking build up crown. And then I go, does a direct composite add longevity to the tooth's life expectancy or decrease it? And I would argue, in this case, a direct composite will add longevity to the tooth's life expectancy versus decreasing it. And in my mouth, this is exactly what I would do. So if I opted to restore directly, now the next question is, what is the best way to maximally, well, I should say, what's the best way to maximize the internal strength and minimize really potential fractures? And so I'm going to introduce you to now short fiber reinforced composites. So for the majority of you, you don't know what they are, and I get that. I didn't know what it was until I went on a trip to Finland, to Turku, Finland, and I got to meet researchers who've been working on short fiber reinforced composites for almost 20 years. And GC America was the one who involved me in the trip to Turku, Finland. And now I'm going to get to share, I think, an amazing product to all of you. So what are these short fiber reinforced resin composites? They're basically composites that have glass fibers placed in a variety of orientation. They could be parallel, they can be perpendicular, or they can be variable. In other words, like at random. So their shapes or their orientations aren't one way or the other, they're just randomly placed. And the reason they're placed in a composite is to enhance the physical properties, and specifically in load-bearing areas. So this is a product that I've now had in my practice for over a year. I couldn't imagine not practicing with this. I've reordered this countless times, and it is a flowable composite. They have a packable in Europe and a flowable, but I believe only the flowable is available in the United States, and it's called Everex Flow. It is a fiber reinforced flowable composite that provides high flexural strength and high fracture toughness. And you can use this either in a bulk fill or incrementally applied. So one is a 5 millimeter bulk fill, or one is a 2 millimeter, and I'll show you more. So in this picture, you can see the randomized particles, the way they're lined up. They're random. They're all coated with a silane, and they're all interspersed amongst the resin composite. And all they're going to do, well, I won't say all they're going to do, but what they're going to do is provide an amazingly higher, excellent fracture toughness for the core. So silanization and impregnation of these fibers with a resin improve the hydrolytic stability and prevent water absorption of the composite, as studied over 15 years ago by Gurushi. So this is nothing new, well studied, and this is the formulation that is in Everex Flow. As I said earlier, it's bulk or a dentin format. The bulk is obviously more translucent than the dentin color. The makeup is 30% resin, 45% filler particles, and 25% filled with fibers. And that's the unique part of this, the fibers. And when you look at why, look at Everex on this, what we call fracture toughness scale. And fracture toughness means we're trying to minimize crack propagation. And Everex flow compared to all the flowables is almost, I'd say, 70% greater in fracture toughness, 70%. Okay, that is scientifically significant. So again, we're going to walk you through how we use this material. And in many ways, it's replaced challenging post where I may want to put a post. Like in this case, no way was I going to put a post, or in large core buildups. And this is just a routine product when I'm rebuilding teeth. So one of the applications, and you'll see in the literature, again by the same author 5 years later, okay, is that they also have a positive impact by decreasing polymerization shrinkage stress. So if you have less shrinkage stress, basically less marginal micro leakage, it becomes almost an ideal material to rebuild the core of the tooth. So let's take a look of effect of these fibers on the fracture resistance on endodontically treated teeth in a study by different authors 7 years ago. And this study was to evaluate the fracture resistance of root canal filled teeth restored with Everex posterior, not the flow, but the posterior. But the posterior. But again, same characteristics. So they had 50 molars and they were divided into 5 groups of 10 each. No treatment, canals were prepared and root filled, no coronal restoration was placed. Teeth were coronally restored with a composite. Composites were then also restored with this, this fiber insertion, or composites were placed over Everex posterior, okay? Now, if you look at this, and I want to go over this really clearly, number 5, group 5. So a composite resin was placed over Everex posterior. And why was this the ideal treatment? There were no significant differences between Everex posterior and intact teeth. Placing this material under a composite increased the fracture strength of a root canal filled teeth to the level of intact teeth, was their conclusion. So now, if you have a lot of tooth left, minimum parafunction, ideal occlusion, you have something here that could potentially minimize future fractures on root canal filled teeth. So one approach is what we call a biomimetic approach. And in this case, it would be a biomimetic composite structure where you have the short fiber reinforced flowable resin as the base, and then your conventional resin composite to replace the enamel. So here's what it would look like. The concept of a biomimetic approach, as you can see the little fibers, they would rebuild the dentin, and then you would place a composite over the top of these in a biomimetic direct approach. So studies have shown, obviously, higher fracture toughness and higher flexural strength. Ideal. So what I want to do is, let's take this research and now apply it clinically. So as I start to rebuild this tooth, I did not have to do crown lengthening. That was a plus. And I'm going to talk about, if I had to, what would I have done? So obviously I'm going to use a sectional matrix band. And openly, the key part of this is to make sure the wedge is below, way below, the height of the wedge is below the contact. And oftentimes I trim the height of my wedge down, and then I'm burnishing the band so I can feel the adjacent tooth. And the adjacent tooth must, the band must be very stable. You can't have any movement in the band. If you have any movement, you could develop an open contact. So rule one, the band must be stable. And as you're burnishing, you should not feel that wedge. The preparation. To begin with, I want to have a sufficient depth within the canal to create an adequate seal. I'm going to bevel with a football finishing burr, usually 50,000 RPMs. You can still go 200,000, but I'm going to bevel the occlusal, and then I'm going to micro etch internally the preparation. And I'm going to tell you, when you're cleaning the canal orifice and your preparation above the canal, this becomes a critical point in long-term bond strength. There are many micro etchers on the market. This is actually purchased through Schein a number of years ago, called AquaCare. And the canal was micro etched with a particle size of 29 micron alumina. And the whole idea is to clean the canal itself. So you've taken out the gutta perch, and you know what it looks like. You got all that scraggly gutta perch in the canal. You got cement. You got to micro etch it to increase the bond strength. On the left is what it would look like under a microscope, dirty. On the right, clean. This is why we do this. If you bond to the left, you're just not going to have the same inherent bond strength. Obviously, if you bond to the right, you're going to increase your bonding tremendously. And the studies are so numerous. This one came with Coyce as I would say, part of the research project. And it just talked about, even when you're doing a resin luting procedure or resin luting cement, what is the effectiveness by micro etching? And very often I micro etch my preparations before I cement. So taking the same thing, this was the summary. The summary basically shows, that the particle size is really not important. Whether it's a 27 or a 50, it's really not that important. The key is doing it. So using low pressure, small particle abrasion really will enhance the bond strength. This is a must. You got to have micro etching in every operatory. After I've cleansed it, now I'm going to totally etch for 15 seconds. After I rinse that area, surgical suction and blot dry, I then place my universal bonding agent. Yes, I'm a universal bonding agent, and I will scrub the area for a full 20 seconds and time it. I'm scrubbing the entire area and the margins for 20 seconds. And now I'm going to air dry routinely for 10 seconds my bonding agent, not 2 seconds, but 10 seconds. And why air? If you lift up your air water syringe, you know what happens. Water comes out. You hit air, you aim it at your knee, you aim it at your forehead, water comes out. So you think by then just keep hitting the air, the water stops, but it doesn't. And studies after studies show water vapor comes out of your air syringe even as you think there's no more water. Well, if you put water into your preparation that you bonded to, you've just ruined your bond strength. So one of the things you do in every operatory, you should put an air-only handpiece, air only. So I have air, water, and I have air. And it's just, syringes. It's just that simple. So you're going to air. And when I air, I start at a distance for about 5 seconds, and then I come closer. And then I hit it a little harder. So soft to hard. That's what I would recommend. So you've etched, you've applied your bonding agent for 20 seconds, and that is the air technique. I will tell you the #1 reason for sensitivity. No, I do not use Galuma. I just don't use these products for this reason. I don't need to. Because if you follow the steps in air drying the right way, you just should not have sensitivity. So in this case, I've now light cured. my box for a solid 20 seconds to 30 seconds, the entire area, box and the canal, 20 to 30 seconds because you're at a distance. I'll get into that more in the next case. Now, what you're going to do is you're going to apply a self-leveling. I like a self-leveling flowable composite. So in the past, I've used SDR Flow Plus. I'll show you other options. I'm going to build my gingival box, and the products on the market that are similar to SureFill SDR Flow Plus. One is from Shofu, and it's called Beautiful Bulk Flowable because it's a bulk flowable that self-levels, just like SDR, and Extra Base from Boca. They all self-level over 5 seconds, and they can be 2, 3, 4 millimeters in depth. So that's the first. How long are you going to like cure? Again, based on depth, I would like cure 20 to 30 seconds minimum. 20 to 30, 10 seconds, you're not going to like cure long enough. Why? Flowables take longer to cure because they're more filled with resin. So you're further from the light. You've got to cure longer. Again, 20 to 30 seconds. So let's talk about this. So here you're placing your flowable. You're going to wait about 5 seconds and let it self-level. Then you're going to take your light straight down and cure for 10 seconds. Then you're going to tilt it from the buccal, tilt it from the lingual, and cure 10 seconds. Why? I have seen so many brown lines along the proximal areas of a box because they weren't cured. You've got to cure them. So if you take the far left one where you're just coming straight down, you would have missed the proximal area. And it's so easy to mix a proximal area. So I believe in curing 10 seconds straight down, lingual, then buccal. So there's your proximal floor. And now I often will inject the same flowable just over the gutta percha, just a thin layer over the gutta percha because it will just self-level and create a seal. Now Everex bulk. Now I'm going to place Everex bulk, and I'm going, and it's basically going to place the tip inside the material, and you must keep the tip inside the material. As you're injecting, just like a flowable, you don't want to create any air bubbles. So inject slowly, and it kind of comes out like Vaseline. And I would openly say you're going to need to give it about 10 seconds to self-level. You can even start packing it with a micro brush after about 10 seconds. So in this case, I injected this over the SDR Flow Plus into the canal, and I definitely did not put more than 4.5 millimeters of material as far as height goes. I didn't do that at all. I'd say it's probably 2 to 3 given this preparation on a bicuspid. So I'll inject 2 to 3 millimeters because I've got to leave room for my final capping layer. And there you can see it. So I'm leaving about 2 millimeters for my final capping layer, but now I'm injecting literally a fiber reinforced flowable composite to minimize fracture. Forget a post. Forget a post. You don't need it. So after about 10 seconds, you can pack it in and you can remove any excess with a micro brush. So I'm building this in the center and over the proximal over the SDR. This is from my buddy Ron. And you'll just see when you're injecting it, it looks a little bit like Vaseline. Let it self-level for about 10 seconds and then pack it. After I light cured this material for, again, 30 to 40 seconds, okay, with directional curing. Now I'm ready for my final layer. But I want you to realize the shrinkage of short fiber reinforced dental composites is ideal. Compared to conventional composites, these have less shrinkage stress and you're going to have less gaps. So again, this is just another reason why I love using this as a core material. Now, as fine as a final capping composite, in this case, I use a MyRefusion Bulk, I love it. It's a universal composite, and it's just a beautiful composite. After I remove my matrix bands, I'm using my light to cure from the buccal and lingual to maximize my curing. So whenever I do a class 2 and I take off my matrix band, I'll just cure 10 seconds from the buccal and 10 seconds from the lingual. Finishing and polishing. Got to just show you. So routinely, I do most of my finishing at 50,000 RPMs. I have converted all my operatories that are restorative are all electric now. I think NSK walks the walk. I had one issue 3 years ago, and Steve, my rep, just came in and just took care of it. They're just a great electric handpiece company, and obviously they have a lot more products. I just give a resounding endorsement to NSK. But openly, I will tell you, electrics are just light years ahead for me as far versus air. And the reason I say that, I can dial down specifically, and you'll see more in the next case. Here I'm dialing down to 50,000 RPMs, and everything has water and light. So I'm going to adjust my occlusion with a red football and a yellow football routinely at 50,000 RPMs, just like this. At the same 50,000 RPMs, I'm going to take my needle nose finishing, again, usually a red or a yellow, ultimately a white. And I want to finish down my proximal junction for any bulk. So just again, the distal buccal and the distal lingual here. I'm just always going composite to tooth, not tooth to composite. Composite to tooth, because I don't want to gouge my composite. When I've got that all smooth, then I use Shofu Super Snaps. There's no metal piece in the middle, so I don't get any scratching. And I basically use 2 speeds. With a black disc, which is coarse, I dial this down to 6,000 to 7,000 RPM. So there's a little speed adjustment by the yellow arrow. I just dial it down to 6,000 or 7,000. And then it goes purple, green, and pink. And this is how I do my finishing of my proximal line angles. When I'm done, here's my final contact. Notice the emergence. It's long and deep. I'm not going to get food trapping in there. I routinely round my marginal ridge just slightly with my black and purple discs, just to round it over, make it easily flossing. Again, step by step. So when I look at my final, the question is, was this tooth half full or half empty? Now, you can look at the molar next to it and say you could restore that. It has nothing to do with this. The key is will this restoration last 10, 15 years? I absolutely believe that, to get her to 50. If it needs to be replaced at that point, we'll replace it at that point. But if I can minimize fractures, if I can minimize stress, why would I want to put a crown on this tooth and almost have nothing left of the tooth? This is why advancements, and specifically GC America's what I call fiber reinforced flowable composite, are just huge in our practices today. People are living longer. Let's be more conservative. So what if in this case the decay was so deep that you couldn't get a sectional matrix band on the tooth? And you could either do crown lengthening or raise the margin, which I'm going to show you in the next case. Well, the literature, it's just really interesting. The treatment prognosis of restored teeth with crown lengthening or deep margin elevation. So they actually have studies comparing crown lengthening to deep margin elevation. Author's conclusion in this study, which was only last year, based on the limited evidence, it was concluded that for restorative purposes, crown lengthening surgery can be successful in long-term retention of restored teeth. However, the deep margin elevation technique has a better survival ratio. So again, there's always 2 sides to look at everything in research. I look at every patient differently, and you'll see that in the next case. Welcome to Michael. And consistently, there are always issues with implants. So in 2014, he came in with this area here. 2014, if you look at the upper implant, tight contact with, I think, the canine. His hygiene was terrible. We've gone over this with him before. He was put on Perio Protect after this, another day, another lecture. But openly, there's that little area, so easy to miss. We now have Pearl already in our practice, which is an artificial intelligence for 2D x-rays. I would tell everybody, you got to go look at Pearl. This is a home run. Pearl would identify this and you wouldn't miss this. 2 years later, he comes in with this. And you're like, you know what you say. This is just like a disaster. He has no symptoms, just food getting stuck down there. And why? Because it's a larger embrasure. It's an atypical embrasure because of the implant. The contact is there. Look at the top implant. Sorry, look at the top implant. You can see migration of the anterior tooth. We'd already restored it and it migrated more. Yep. So how do we predict the future with implants? So here are the problems. Implants don't move. Natural teeth move. They just move. They're going to move routinely in an anterior position. They can move posterior, but not in this case. So you develop an open contact. On the bottom, you can see where I've outlined in blue, large embrasure, much larger than a normal embrasure of natural teeth. So routinely, the issues with implants are open contacts, proximal caries from large implant tooth embrasures, and Tarnow study totally support this. So this was done, this study came out 4 years ago. And look at how much contact loss starting within 3 months to 5 years. In the maxilla, it can be 18 to 66%, up to 54%, but 37% minimum in the lower mandible as early as 3 months. So here's what I'm going to tell you. You need to be putting people in retainers. I'm just telling you, you got to put people in retainers when you restore them. Their teeth are going to shift. You can almost guarantee on a tooth number 19, you're putting an implant in, and if there's a light contact between 20, 21, or 22, you're going to have migration. So we put patients in retainers, and we tell them right up front. I know you haven't heard this, but that's what we do. And for perio patients, that's a whole nother story. We put them in Perio Protect because implants are more susceptible to perio than natural teeth. Less plaque will cause more perimucositis than gingivitis, based on the literature. So preoperatively, you can't see anything. It's just a food impact scenario. 30, sadly, was a cement down. I wish it wasn't. If it was a screw down, I would have gladly unscrewed it, put a new screw in, and had lateral access. So what were my options? We could remove the cemented implant crown. We could, but I could damage the crown, and that would create another issue. You can identify where the path is on an x-ray, but you don't know if it's tilting buccal or lingual. You've been there. You start drilling in the central fossa, and then all of a sudden the access is more to the buccal or lingual. And now the crown may have to be redone. Oh, that's a fun moment in the chair. You could come from a lateral. And so you could come laterally, and then you could use a Tafelmeyer band, and you create an access hole. So what would happen is you drill from the lateral side, then you put a Tafelmeyer around it, and you put a hole in the Tafelmeyer to give you access. And then you could inject a composite or a glass ionomer by a composite, but you need proper wedging, which is always a challenge against an implant, but it's an option. I've done it. You could drop a box for a deep class 2, but there are also challenges in creating an ideal class 2. So these are the challenges of restorative dentistry. How do you isolate that gingival box and get a great emergence? How do you get a great contact? How do you protect the pulp? How do you do selective caries removal? How does a wedge against an implant? That's not easy. And do you really charge a 2 surface for this? Are you kidding me? Not a chance. Not a chance. You're sitting there and you're going, oh, I hate these. I schedule an hour. I forewarn we may pulp out. I'm hoping not. He's asymptomatic. I definitely don't want to pulp out. So I'm going to drop a box. So I'm going to use 200,000 RPMs, single-use diamond, and I'm going to use a wedge guard to place between my implant crown so I don't nick it. So I'm dropping the box at 200,000 RPMs. You want to finish the floor, you can lower your output, your RPMs to 50,000 as seen by the 2. Those are both my 2 of my 6 presets with my NSK. Now I have excess tissue in there. I have a CO2 laser from DECA, and then I also have wonderful diode lasers from Ultradent. In this case, I'm going to use an activated tip, set it at gingivectomy. Patient's going to wear protective eyewear, and I'm just going to remove the excess tissue. I'll then use Astringent X, also an Ultradent product, to control residual bleeding, period. I just remove the tissue, little residual bleeding with Astringent X. So I've got my prep, remove the tissue. Now, I've dropped my box, and now it's time for selective caries removal. Now, this is critical. These are burrs made by Comet. They are ceramic burrs. If you've heard me before, you know I've been talking about these for 10 plus years. I still use them every day, and a preset on my NSK is either 1,500 RPMs or 2,000. It's a rotary speed ceramic caries removal burr. So all I'm going to do is remove the mush. I don't want to pulp out. And the research on caries removal goes back almost 60 years. So back to Mertz-Fairhurst in 1962, with follow-ups and follow-ups and follow-ups, that you can treat deep caries lesions by partial caries removal. I know the University of Iowa Dental School and many others are now teaching this. It's okay to leave caries over the pulpal tissue, protect the pulpal tissue, make sure the caries is away from all your walls so you can create a seal. It's all about proper caries removal. You want to stepwise remove the enamel and the dentin, initial caries. Make sure you can create a seal, but you do not want to risk a pulp exposure, period. So forget the days you got to remove everything. That is just wrong. The key is, so you have some bacteria and microorganisms. If you place the correct liner over it, which I'll show you, and you create a seal, basically these microorganisms are going to be entombed and die. Professor Kidd found leaving infected dentin does not result in caries progression, pulpitis, or death. And indirect calcium hydroxide pulp caps further seal and heal. So why a calcium hydroxide liner? Just you got to understand this, not a lot of the other liners, but a calcium hydroxide liner. They have antibacterial properties. They can seal the dentinal tubules against the ingress of microorganisms. They allow remineralization of dentin, and they protect the pulpal tissue from the negative effects of restorative materials. These are 3 that we have used in our practice, and the latest is Ceramer. And I would tell you, based on Nate Lawson's study, Ceramer has twice the calcium release. I don't know about Limelight because they just now released the enhanced, but it has twice the calcium release of other traditional calcium, resin calcium hydroxide liners. You have to understand that calcium hydroxide disassociates into calcium and hydroxyl ions. The ions that are hydroxyl ions are alkaline, and this is essential for really, I would call it bioactivity. And this alkaline nature is antibacterial and leads to wound healing. So calcium hydroxide breaks down to calcium and hydroxyl ions. The monomers are just very, very hydrophilic. And as they enter into the tubular fluid, they will release calcium to create new apatite. Now, because the monomers are hydrophilic, you want to leave the dentin mildly moist. So after you remove the decay and you've done your thing with your Cereburs, what you will then do is you'll rinse the area off, blot dry it, don't air dry it, and leave it just minor moist. Then this will flow. There's no fluoride in this, and you don't want fluoride by the pulp, not at all. And these products are all low in solubility. So let's talk about elevating the margin. You've placed your liner, now we're going to elevate the margin. So what you're going to do, and here's your steps, you're going to take a Tafelmayer band, you're going to cut one wing off. So you're going to take a Tafelmayer molar band, you all have them, cut 1 week off. As you cut 1 week, you're going to take the winged portion and place that over the deepest area. Do not wedge. No wedge, just tighten it. This isn't going to create the contact. You're just elevating the wedge. Once your band is on tight, clean the area, rinse it, blot dry, and make sure your micro brush is not wet. That ensures you don't have any leakage, period. You're going to etch. Now you're going to rinse, blot dry, and you're going to again place your universal bonding agent. And again, after you're blotting dry, after you place your universal bonding agent, you're going to go from mild to heavy air for 5 to 10 seconds, and you're going to like your 30 seconds again, because you're far away from the light down. You could be 10 or 11 millimeters away. The further the distance, the longer you light cure. Same thing. 11 millimeters. And when you put the matrix band on, your light is on top of the matrix band. So this is why you've got to cure multi-directional for 30 seconds. Don't be stingy on time. Same thing. I'm going to place the same flowable, one of the 3, in the bottom of the box and let it self-level. Then I'm going to take off my Tafelmayer. I'm going to re-prep the box to get a smooth gingival margin. I've raised the margin. Forget the contact. I've just raised the margin. So there's no concavity. I've just raised it for a proper emergence. So I'm going to refinish. Then I'm going to put a sectional matrix band back down. And in this case, I had to use multiple wedges. Then I looked down and said, nope, that's not good. I can see one of the wedges, take everything apart and redo it. But again, I'm going to use a molar sectional matrix band, multiple wedges, because I'm next to an implant. I'm going to use the original unidose from my bonding. And when I bond a tooth or multiple teeth, I just put Teflon tape over my unidose. And why? Because I don't want the solvent to evaporate, but I don't want to just pop a new one and a new one and a new one. I'm a dentist. I'm cheap. So again, you're going to start with a unidose. And then my assistant always knows, have Teflon tape out to stop the solvent from evaporating. So now I can open it again. I've etched. I'm going to reapply my bonding agent over the original SDR. And then I'm going to just obviously, again, air dry, light cure. And I'm still going to light cure 30 seconds. So I'm going to then put more SDR flow in. And again, I used Admira Fusion bulk. So when I'm done, you can see the Admira Fusion on the top. the SDR in 2 layers. So SDR first layer was with the molar band. Take it off. You can even light cure again. Then you're going to put on your sectional, re-etch, rebond, more SDR to self-level, and then admira fusion over that. Again, you can put on whatever capping layer you want, but I needed more than 2 millimeters, so I wanted to use a bulk fill. And admira fusion, I think, is the nicest looking bulk fill capping product. You can also see the calcium hydroxide liner, how close I was to the pulp, and I did not pulp out. So my final pictures. Yes, the contact, I have broadened it. I didn't want to narrow the lingual contact. I wanted to do a very wide, broad contact. You say that doesn't look natural. Well, if I narrow it, it's going to pack food. So that's how ultimately I rebuild an implant, a contact next to an implant, a long, broad contact by raising the margin. My last one, and we'll talk about selecting the ideal flowable. The ideal flowable, to me, in my practice, falls into this categories. I love GC's universal injectable flow, the G&EL injectable, the G&EL bulk injectable. But I equally love Shofu's beautiful no and low flow plus. And PulpGen just launched Presto. It got stellar Catapult review product, Catapult review. And it is, again, it releases calcium. There's a lot to Presto. The bottom 3 on this could be what we would call bioactive. Again, the beautiful flow line is a geomer. Presto has a whole different chemistry with calcium release. But again, I'm going to show you a bulk fill injectable with a geriatric patient. So the chief complaint was, I'm getting so much food on this back tooth. And this is typical of geriatrics. How do we close these embrasures? And again, this was Marvin's big issue. And we have to create the proper contour to close the embrasure. And again, part of this is we've got to seal that gingival crevicular fluid also. So what do? I use these BioClear matrices, bands. David Clark is a genius, and many of his minor that I think are major inventions. I use these to close black triangles in the anterior, but I can also close embrasures in the posterior. And this is big because I don't want to just do crowns on my geriatric patients. So this is the size tall average for the molar, and they all come in different sizes from BioClear. And you can see there's a little lip right there that creates a beautiful, what I call emerging contact, emergence to the contact. And on the bottom of the area, that's how you're going to hold it and pull it out. So I have now either pre-wedged the teeth apart so I could slide my matrix down, or if the contact was light, I would just slide my matrix down. Pre-operatively, I would roughen the area with a diamond burr or block out the area and micro etch. Blocking out the area means to cover the gingival tissue so you don't create bleeding. If you micro etch and hit the tissue, it's going to bleed. So routinely, I'll use ultradense blockout putty or a blockout, like a bleaching tray blockout material. I'll just put it over the tissue and micro etch. If you don't want to do that, then just take a diamond finishing burr and roughen that area just to remove, and to really to remove the smear layer and any what I would call dirty surface. So after I've etched, I've actually removed the band here. You could leave it in place. And now I'm just going to take another universal bonding agent and scrub it from the buccal and the lingual for 20 seconds. Going to air dry the same way, and then I'm going to light cure from the buccal and the lingual. So in this case, if I don't have the matrix band on, I know I'm optimizing my bond strength. I place the matrix back in, tuck it underneath the tissue. And in this case, I injected from the buccal G&Neil bulk injectable. It's got this ideal flow. And as I inject it from the buccal, it will flow out to the lingual. You can then hold it on the lingual, hold it on the buccal, and then just cure buccally and lingually. After you cure it, you take a piece of floss to separate the matrix band, the BioClear matrix, from the adjacent tooth. Routine presets for finishing. I know I'm running a little late. Back to my 50,000. And then I'm going to finish it again with the super snaps. The course at 6,000. And then the rest at 10,000. I wasn't worried about the gingival area here, the buccal areas. No sensitivity. He's 90 years old. I am just trying to block it out because the food entrapment was his #1 issue. And you can see how beautiful the BioClear allows me to shape the contact area. And you can also see how wonderful this material is. Just always keep your tip in the material to avoid any air bubbles. So this is a great case for G&Neil bulk injectable. So the goal of my program tonight was really to show a few different concepts: caries removal, case thought, crown versus composite, core versus fiber reinforced composites, closing embrasures, and really also raising a margin, how to raise margins. I know a lot to take in an hour, but those are my challenging class 2 situations. And I wish you the best as you face those in your future. Adam, I'm absolutely willing to take Q&A. I'm going to read a couple first, and please type in your questions. I'm in no rush, happy to help. Is this similar to fiber core tape with composite to making a core, to make a core? I'll be honest with you. I know you're an anonymous attendee. I don't know what fiber core tape is, but this is not tape. You would never know these fibers are embedded in Everex flow. You just don't see them. So this is just, you inject and everything's all in one. So I'd say this is pretty simple. Then Lucia asked, did you say etch and bond again over the elevated margin? Absolutely. So let me be clear, Lucia. So after you removed that initial Tafelmeyer, I then re-prep my proximal line angles and my floor. So now I've adjusted my line angles just to remove any debris. And I've also adjusted my SDR. So then when you put your sectional matrix band back on, you will re-etch and then reuse your same bonding agent. But remember, cover it up. Now, if you're using a bottle, fine, just shake it and go back. But again, I just love single use. But yes, you re-etch and you rebond over your elevated margin. I hope that helps. What light do I use? I'm a Velo guy, Ultradent Velo. That's what you saw. That was the Velo Grand. Okay. Rashmi goes, do these different materials bond well to each other? The answer is absolutely. Now, if you're asking me about a Voco material, which is an Ormacere, over a regular flowable, the answer is no problem. If you're asking me about a Everex flow with a capping agent, no problem. The literature shows these are resins, and resins bond to resins. So I absolutely, Rashmi, have no issue using different products following the instructions. But thank you for the question. How do you ensure no overhang with a BioClear matrix on the posterior closure? So openly, Scott, there is no guarantee. So routinely, I'll take an X-ray. And just 2 weeks ago, I did have an overhang. And I can take interproximal finishing strips. Many companies make them, unless it's a gross overhang. And then I would just use one of my diamond needle noses to go composite down. But there is no guarantee. But my feeling is if I use a wedge all the way down there, I'm going to get a negative contour. So in that case, I really prefer not to use a wedge. But am I perfect? No. So I would just say, that's how I would do it. So then Alina goes, how do you correct overhangs? Well, the first way is Dentatis makes the Profin, which is a great way for IPR and removing overhangs. But that's a device. I love that device. But there are plenty of strips made for removing excess composite. If it's gross, I'll use a needle nose, just going straight down, and then I'll use my strips afterwards. Okay, what sandblaster do you use intraorally? What I would say, again, to my attendee is because the particle size really just needs to be small, like under 50, if you can hook it up to your air in your operatory, I would use, honestly, any inexpensive micro etcher. The micro etcher I used is a dual micro etcher, but openly, anything that can connect to your air would be all I would use as my micro etcher. Okay. Another question. Do you remove all the gutta percha to the furca on the bicuspid case you showed and replace it with composite? I'll remove a couple millimeters. Will I go all the way down to the furca? Heck no. I don't want to perf anything. I'm not perfect. I'm like you. I'm looking through my 3 or 4 powered loops. No, I want to go 2 or 3 millimeters into the canal, remove the gutta percha, and going all the way to the furca, I don't see the benefit. I just don't. So no, I'll just go down. If it's a millimeter gutta percha left, I'll leave a millimeter. Really doesn't matter because all I'm trying to do is get a seal within the canal. That's how I look at it. Nick asked, how do you adjust a deep interproximal? I think we covered that, Nick. Payam, how about using Fuji 9 and a sandwich technique deep subgingival? Well, I'm going to tell you, I used to do that. I used to put glass ionomers down, then I found I would get voids. I also found that if I do glass ionomers deep, when my patients would come in for hygiene visits, we'd have to hand scale because ultrasonics gouge them. So I'm not the biggest believer in open sandwiches like I was 15 years ago. I think it's a great question, but I think if you can isolate, you'll be fine. And also, I'm sorry, but some people could say, when I'm doing that, are you 100% sure? No. But I would absolutely say that to me, I'm just worried about long-term gouging the Fuji 9 when I'm doing ultrasonics. Okay. Do you find G&EL harder to finish? No. I definitely find G&EL flows ideal. They can be used in class 1s to 6s. They're just, no, I do not find them harder to finish at all. Question, do you use the 4-second feature on the Velo light? The answer is no. And I'm going to explain to you why. When you do a 4-second light and your light isn't in the ideal location, I'm worried I'm under curing. Now, I know Ultradent says, you've got that turbo, and I think it's 3 seconds, not 4. There's nothing wrong with it. You can absolutely do it. But I know with those 10 seconds, I'm holding it in place. You're not doing anything wrong if you're using it for the 3 or 4 seconds, but you better, if you're doing it that way, hold it for 3 seconds, angle it for 3 seconds buccally, and angle it 3 seconds lingually. I just know with 30 seconds, I'm really covering it, but there's nothing wrong with the 3 or 4 second from the Velo, but please angle it. One direction is not enough. What retainer do you give to implant patients? So what I do is after I deliver the implant, I'm an iTero guy. I scan them after it's done and they get the retainer. Now, if you're making your own retainers, great. My labs make my retainers, so they're all lab driven retainers, just letting you know. Why do you want a liner with fluoride over the pulp? So if you read the literature, fluoride is toxic to the pulp. I'm going to say it again. Fluoride is toxic to the pulp. So even if you're placing a glass ionomer like GC's glass ionomer deep, I have no problem in a closed sandwich. But if you're placing a glass ionomer near the pulp, go Google glass ionomer, GC or SDI. They make another great one. So does Voco. They say if you're near the pulp, put a calcium hydroxide liner because fluoride is toxic to the pulp. That's why. Okay, next question. Do you worry about a small gap between your gingival margin and your sectional matrix? Or would you expect to flow beyond the margin to provide a good seal? I've heard this from some people. I worry about an overhead. So openly, let's just go back to me raising my margin. When I raised the margin, I'm good with time, so I don't want anybody to worry. I want everybody to be happy. When I'm raising my margin and I'm placing, let's say, SDR over SDR, could you develop a little overhang? And the answer is yes. It's how well you adapt, Louisa, your sectional matrix band to the tooth. So I want them really, really tight, and I burnish, so I can feel my little ball burnisher on top of my raised margin so that I'm clearly getting that flow. And God forbid, if you get a little overhang, use a strip, place it underneath the contact and just remove it. You'll be okay. Okay? Can you use a sandblaster intraorally without the rubber dam? Yeah, I do. So what can I tell you? I do. Not all my cases are with rubber dam. Shoot me, but they're not. Okay, like if you use an isolite, it's not a rubber dam. I'm still going to sandblast. So let me just say this. So let's say you're cementing a crown, and your crown, you're using a resin cement. You take off your temporary, and you got all that cement still stuck on the tooth or part of it, and you want to clean that tooth. Routinely, what I'll do is I'll inject a blackout material. Premier makes it. It's blue. Ultradent makes it. I black out the gingival tissue, light cure it, and then I micro etch the crown. And when I remove the blue, blackout material, if there's any bleeding, I use a little astringent and X, wipe it for 10 seconds, and the bleeding's gone. But now you have an ideal preparation that you can bond to. And I'm sorry, so many of our preps are not ideal, including mine. So if you're going to bond to a tooth and you've got temporary cement and gradue all over the preparation, you're not going to have high bond strengths. So again, I just micro etch those. Okay. Nick asks, are you worried about the flowable squirting out the gingival seal of the matrix if you packable over uncured in the box? Okay, so we're back to the BioClear method. Are you worried about the flowable squirting out the gingival seal of the matrix if you packable? I'm not packing. I want to be clear here. With the BioClear, let's be clear. All I did was I put my BioClear band in. Now, the band has this little cup. It's coming from the gingival. You could put a wedge in there if you want to. I have no problem. In this case, I didn't. But I have no problem if you want to put a small wedge in there, but routinely you're going to have to put a big wedge. Then you're going to have to cut the height down. But Nick, I am only injecting the bulk fill injectable from the buccal, and it will fill the lingual all the way to the buccal. I am not packing. If I packed anything over it, yes, I would be much more worried about it coming out. So just letting you know, I'm just injecting the flowable. Okay. And if you want to use a small wedge, I'm okay with that. Okay. Last, hang on. I think I have covered them all.
You certainly did. There might be a couple in the chat for you.
Okay.
Yeah, I'm just trying to see which ones are duplicates.
Let's go to, okay. How do I bond to calcium hydroxide? Rob, let me just tell you, the calcium hydroxides on the market are not like old Dical, which was just old Dical. These are resin, really resin modified calcium hydroxide sealers. So if you understand there's resin in them, you've light cured, these are all light cured. So when you placing your flowable, your etching and bonding in your flowable will bond to your resin modified calcium hydroxide liners. And that's how it works. Okay. Okay, one other question was, would finishing fiber reinforced composites pull the fibers out? Absolutely not. The only place you'll see, potentially not see, there would be any fibers would be on the proximal wall because you're routinely capping the occlusal. I have never seen that at all. And I think it actually finishes darn nice. So no, finishing burrs do not pull fibers out. Haven't seen that. And I think, Adam, I think we're done. I think we're good.
I think you knocked him out. There may have been an earlier one. If something gives off calcium, isn't it dissolving?
So the idea, if something is giving off calcium, the whole idea is that calcium itself is a precipitant to calcium hydroxide or calcium apatite. We're trying to make new hydroxyapatite. So it will be absorbed by the tooth, yes. And the whole idea is to remineralize the tooth with that calcium. That's the goal. And you want an alkaline property. All these biomimetic or bioactive products have alkaline chemistry and release calcium. That's our goal. Yes.
Excellent. Now I think you answered all the questions.
Okay.
Cool.
Adam, I thank you. I thank Schein. I thank GC America and Michelle. Thank you all for a wonderful evening. I love the questions. Hope to see you on the road. Thank you.
Excellent. Well, you made my job super easy tonight, so always appreciate that. Thank you so much, Dr. Graham. If anyone does have additional questions, feel free to email webinars@henryschein.com. And we did record the webinar tonight, so we'll get that out to you in a week or so. Thanks, everyone. Have a great night.
Great night.